Welcome everyone to NeuroTalks. Today we have a very special guest, Dr. Demetrius Lopes, who is the head of the Department of Neurosurgery at Advocate Health in near Chicago in Illinois. And I would like to thank you for being with us. And I know that you just came from a procedure. I hope it went well. And thank you again for joining. We are talking today on about COVID and how COVID is important or might change our life in interventional neuroradiology forever. So Dr. Demetrius will address that that subject. And so thank you so much. How do you think COVID is changing our practice?
Tiago, thank you so much for the invitation. I think that this is a very relevant topic. Maybe we'll separate in different phases. I think there's no question that this pandemic just exposed a lot of issues we had in our healthcare. I think that this is making us rethink a lot of ways how we take care of our patients and healthcare in general. So for sure, it will change healthcare forever. And I think maybe the best way to start thinking about this is look at how today we share information. So how everything was happening in China for a period of time and then rapidly spread through Europe and Americas afterwards. How the knowledge was shared from what is happening in China to the labs in Europe and then the United States. I have to say that it was, I think we can do much better than that. And I think we had to learn a lot of the new, let's say, precautions and the new way to take care of patients on the fly. We had to learn this in a very quick manner. But I have to think that in the beginning, there was a sense of fragmentation of how the information is passed. And over the 2-3 months that went by from the onset to then wide global spread, we had to identify ways to share the information that I don't think will ever go away. I think today, the amount of webinars and how the medical knowledge is shared will always continue to grow in this path of quickly being able to do a procedure or change a technique and then spread that through the world in that fashion. I think in the past, we waited a lot for publications or meetings to be able to have the knowledge shared. So I think that's one aspect that will change forever for sure. I do think that we also have to adapt quite a bit on how we our relationship with education and training. Today, there's a lot of concerns of how do you maintain your fellowship and your training when you cannot you want to minimize the number of people in the lab. And for sure, this particular year, whoever is in graduation or is going to graduate, it will have an impact on the number of cases just because of the time that we have to dedicate to take care of patients with COVID and not focus so much on cerebrovascular disease. I think that this exposed our fellows and residents to a different level of activity. So they were busy and involved, but at the same time, they may not get as many elective cases as they were supposed to. So then the room for simulation and thinking about creative ways to get their exposure to them on the time that is left is also going to be something that will change. I think we're going to be focusing much more on knowing what the curriculum is and not fill that only with cases, but also with simulations and also lectures that are going to be done on with a kind of a much more use of webinars also for residency and fellowship training. And I think that's going to be a big change, certainly for this class, but also moving forward. When it comes down to medical meetings, I do think that this is going to be something of larger impact too. We have WNC platform, as you know, and we are rethinking how to do that meeting. and maybe some of the components of the way we share the platform globally will be done online, and some eventually come into physical meetings too. But there will be probably a decrease in number of medical meetings and more of a use of webinars to kind of concentrate that knowledge sharing with a online platform. Another area that I think is, yeah, go ahead.
No, I was just asking regarding what you are just saying, because we can see that there are many webinars coming. Actually, NeuroTalks is one of these new webinars that just arrived from a personal initiative and after an Instagram page, but has been joining people from all over the world, actually. So, but now I think that we need at some point some kind of certification of webinars as well, of basically of online training, because we don't have that for the time being. Also, many webinars are actually sponsored by many companies in a very straightforward way, which was not the case in the physical meetings. So do you think that there will be new groups of doctors or new societies that will probably appear, or on the other way around, the international societies that are already established, should they take part of the game and start being more proactive in these online training? Because for me, training on the basis of sponsored, so in such a very direct way, I don't think probably is the best way. What do you think?
Thiago, there's no question that we have seen a very delayed response from I think societies and even the industry. Everybody was I think very surprised and was not prepared for the size or the dimension of this pandemic. And so I think that we will have to see the societies coming along with the new models. I think the models exist. I think that what I'm trying to say is that during this period, we had to adapt, and that was done in the best way that was possible, but it will evolve now into, I think, becoming more official. I think what you said, that follows into my next topic, which is really important. I think you have to say that we had a change on how you're going to document that education is being given, that is impartial, and that you're getting the credits and evaluations that you need to. There will be a validation that you need to know if training that way is as good as we had before. So that period is going to have to happen. But then, remember that also for maintenance of your knowledge, so that actually fits very well for that model. For folks that are already trained and they need to maintain in a high level, that will be a good way to keep their certification and keep them up to date. But the next level that I wanted to talk to you is something that's very big in the United States. I think is worldwide too, but in America, the biggest issue was telemedicine. The ability to do the clinical consultations and not to stop. So now let's talk about what has changed and what will change in terms of patient and doctor relationships. And there's no question. Yesterday, I had a clinic. We saw over 25 patients, all online, all through telemedicine. And why that became all of a sudden, not only there were a lot of barriers before to that, I think those barriers were taken down immediately as the pandemic effort was happening. So we had to all of a sudden be able to have billing codes and the ability to have the productivity checked as you're seeing patients online. This was just not available. Before it was very much a lot of times for free. It was not. There was no way to track that or put into medical records. Now this, I think, one thing that I feel that we as neurointerventionalists have a huge role on this pandemic effort was that we knew from telestroke and for the introduction of the communication platforms for stroke care, we were very prepared in a sense to this type of life. And so I think that moving forward, we're going to be able to be bringing this to day-to-day life. I think we're going to see much more the ability to have less patients traveling from one state or one country to another and have to have access to experts through telemedicine. I think that will be very much a reality. I think that this is happening globally. What's your impression in Europe?
Well, yes, I think it's probably happening the same. What we know, what we are doing now already here, at least here in Portugal, and I guess in other countries that are, well, I know that in the UK is the same thing. People are, like you said, moving towards the teleconsultation. And actually, in our practice, probably we don't really need to have the patient next to us, because probably, and we should be honest, we are probably not doing the neurological examination in the consultation. Probably we are doing that for consent purposes and just before the procedure. But in the consultation, we are not probably doing, as an outpatient, doing the neurological examination. So probably I think that a video or a teleconsultation is completely adequate and is also something that is beneficial for the environment and for other purposes in terms of saving what, well, basically money. But so I agree with you in that aspect completely. On the other way around, and I was thinking in terms of and probably I'm going back slightly in our conversation regarding physical meetings. Well, you know, and I know that physical meetings are not just for learning purposes. The possibility of getting together in the same place and being together for dinners and so on is also a professional opportunity, not only for networking purposes regarding moving to another hospital or something like that, but also to start developing new projects. I remember doing that with colleagues, and I'm sure that you have that experience, and many of our colleagues have that experience. And I'm afraid that if we don't have that social component of our meetings, probably that will be missed at some point. I'm sure that we'll find other ways of doing that. But I'm just asking, how are we going to network without the physical and the contact to be in the same space?
Thiago, I think there's no question that the new normal will be, and I think what you need to think about is that this will happen, and you know, we have WNC as a platform that we have a lot of passion about the live cases and how it's done, but at the same time, the ability to, I think what you're going to see is perhaps a decrease in the overall number of gatherings or meetings that people come together, but have more also the growth of a platform that is online. That I think is here to stay. I think that this is a change, but it will be in addition perhaps to continue some of the most dominant meetings. I think they will continue, and that's when the social encounters will happen. There's value to small meetings, there's value to big meetings. I think that the issue is more, we're going to have an option, and there will be in parallel to that an education that will happen in a form of webinars and web meetings. This is, I'll challenge you with one more thing that's very interesting. We're seeing a tremendous growth on companies that allow you to have, for a relatively reasonable price, the experience of being in the room with the surgeon. So the growth of how proctor is going to be done, how we're going to be able to start new devices will change completely. I think you're going to see now much more. If you have a new device, in the past, we have to have a surgeon coming to your hospital to be there with you to proctor the case. I think that system will be changing quite a bit. I think there are very now mobile systems that can be placed in the lab just for a period of time for the case, and then removed, that bring the cameras in the view of what's happening in the room and in the angio suite imaging to an operator that is away from the room. So that will change. I think that you will be seeing much more industry investing on that type of proctor program. And you can argue good or bad, but I'm just saying that it's coming, and it's something that you will see a change on that too. And it's actually, if you think about robotics, how robotics are growing in our field, and how this type of telemedicine, and now the teleproctor, or the proctor at distance, these type of things are just, they were all out there, but they were accelerated because of the COVID problem. So what we're going to see, Thiago, is a change in life that was basically fast pace, a fast speed, fast forward on things that were already happening, but now they took on steroids. They just kind of took off, and I think it's going to be hard to stop that.
No, I was just asking. I know that you have a special interest on AI as well, and I would like to hear you. How do you think AI will? Because we know how well, we don't know how it's going to change our diagnostic practice. We don't know. We still don't know. But we can imagine more or less what's going to happen. But I'd like to hear from you. What do you think? How it's going to change our practice in intervention as well? And I know that, well, you were talking about robotics. It's going through that, obviously, but it's challenging times when we leave our aneurysm for an artificial intelligence that might be better than us. I don't know.
What happened with AI, it's incredible. This was an incredible time for AI because of it allowed the setup of having your images screened by some kind of tool that does the evaluation of those images for a certain diagnosis. So those different protocols, large vessel occlusion, intracranial hemorrhage, aneurysm detection, all those things, to have that in place in one site is already changing practices. But what during the COVID pandemic, what we saw is that we could get data much faster because many sites were connected to the same platform. So all of a sudden, we could see trends of how many CAT scans are being done, certainly in the United States. This would take forever, and it would be a lot of self-reporting in the past. So now what you're seeing is going to be, I think, because of the AI platforms, all of a sudden you link all the sites globally, and you can quickly get data on what trends are happening. Is this a stroke affecting young people, old people? Are LVO numbers changed, or is just the total number of stroke codes? All those things are going to be tracked in a minute by minute globally. I mean, that's a change. I mean, like, this is no question. You're going to be able to see. You're not going to have to wonder what's happening, or you're going to report on like, oh yeah, we think it's getting more cases of this and that. You're actually going to know that over like 40,000 scans done in the last 3 months, this is the trend. And that information, it was the first time that we start seeing that being applied in such a clinical relevance like that. So we could then, remember some of the things that the pandemic effort were that we need to save safety for our teams. So we needed to make sure our staffing was appropriate for the volumes that we were going to have. But nobody had an idea of how much volume you're going to have. So we needed to have some kind of knowledge. And I think the AI platforms, and it's not the sense of AI per se, but it's just the fact that when you have all the labs hooked up to screen for AI, it allowed the visibility in a global level that we didn't have before. And that allowed us to staff ourselves better and protect our teams. So you see how that whole thing worked out very well for us. I mean, if you look at the numbers of like how we got the information, for example, of let's say, are the stroke trends up or down? What we found out was there's like a 20% drop on overall number of scans being done, but the number of large vessel occlusions didn't change. So if you were very sick, you would come to the hospital, but just the strokes that were maybe more mild, those were the ones that were afraid to perhaps come into the hospital. And but that became very clear on when these graphs start to show up. So Thiago, we have to think that this is changing forever. We're not gonna, this is gonna become part of our reality, is to have much more of a global view of what's happening in the time to time, because AI's platforms are gonna allow us to do that.
Yeah, and so COVID was an accelerator of all the changes that we are probably facing. We have some two questions from our colleagues, but they are similar, and one of them is saying greetings from Brazil. Basically they are asking if well, you have already told us what we think about physical meetings in the future, but also, and something that I think is very important. I believe that these webinars, this new way of learning and this new way of spreading knowledge, if properly done, and I believe it's going to be, probably will improve and will have results in our practice. Because if we go to Link or ESMINT or one of these big conferences every other year, probably you are going to, if you are not every day looking at the new papers that are coming and so on, and we know that many of our colleagues go to these conferences to learn. And if we have the opportunity to learn almost every day with the experts, I think that might result in improved practice, and that might result in better healthcare, and that might be really, really exciting times if we understand that this new way of training is probably being in a very good result for our patients, and that's really, really good. On the other hand, and I would like to ask you this, and that might be a tricky question. Many of the webinars that we are watching, and they all have the big names, like you, for instance, talking on specific subjects. And what it was very interesting in the, and I'm talking in the past already, what was very interesting in the physical meetings, that many people would have the chance to start talking and presenting in conferences, because they would start with scientific sessions. Some of these people would start doing some moderations and then would be invited for lecturing. If we have a group of people that are really, really good, and there is no doubt about that, but it might happen that these people that are not as experienced have less opportunities to present and to show their work, and that might not be so positive. What do you think?
Thiago, I think that this is, I think we're going to be finding different types of venues that will be presented by folks that are, in different levels of training. So I don't think necessarily, I think we can create a platform. I feel that, I think this is good. I think this is, we are moving in the right direction. I think that there will be physical meetings. There will be probably less, there will be a decrease in number, perhaps more consolidation, but at the same time, you will have so many other options online. And I hope that's keep growing in credibility Also, it's important for us to measure how impactful these meetings are. So we're going to have to go through that process of validation of that. I think a few things are also very important. How projects move so fast. We wrote a number of papers during this time. So the creativity and the ability to, what happened during the COVID, I think was that also there was a very important downtime that everybody were able to kind of slow down a little bit, focus on the tasks that we had. Many of us had also think about if you had not to do other jobs within the medical field, because the necessity sometimes was related to ICU care or emergency room triage or other areas. So our teams were placed in different areas of the hospital. It created a sense of that you're back, you're not so isolated as a specialty, that we're much more part of our healthcare. And that we had to have a stroke response, but we had also to fit within the public health and what was going on. I think this is a very good reminder to all of us that we belong to that larger healthcare, and that even though we're very specialized, we have to always bring it back. And this definitely did that. The slowing down of everything in the sense of allow us to see personal projects and things that you were doing. I think that was also healthy and good for us, even though a lot of our colleagues got sick during this time. And I really feel that was a vulnerability that we need to learn how to protect ourselves over time. But the biggest thing for me is that innovations and the ability to develop new things, I think kept growing. We actually had a lot of interactions, a lot of things going on, and new devices and thoughts and projects developed while the pandemic effort was happening. The publications kept going. We put our databases together. I think that the biggest thing for me was the research that involved clinical research. We had to stop that during this period. And I feel that this also created us to develop e-consenting much more, our analysis of data as from review of your data through a more mobile fashion, or something that would be unheard before. You always had to have people visiting your lab to check on all the data forms and so forth. So all those audits now being done perhaps in a combination of visits plus doing from far away. It's a change. I think we're going to see research changing after this to a more modern way, that you're going to have much more of these things done in a really in a more automatic way, with less people interaction and much more like use of the distance, and be able to monitor from distant sites. And I think that this, for whoever does research and has interest in that, it's very powerful, because it will allow maybe better oversight, even because you create tools that you're seeing as it goes forward, the research in a minute-by-minute assessment of what's happening. Before, it used to be perhaps more periodically, because you had to have physical visits to happen. So I think research also was affected. We're dying to return to randomization and get into our clinical trials enrollment. But I think that this allowed us to rethink how research is done, and that's going to change too. I think one of the questions was regarding innovation. Hopefully I addressed that. I don't know if you have any other questions there.
Well, I just have a question from a colleague. Dr. Omar is asking, what about the low-income countries? And that might be a very good opportunity for countries where it's difficult to have access to knowledge and to learning, and these might facilitate this new situation, new paradigm.
I think that you brought up earlier something, and I had mentioned about the proctor and bringing the teacher to the room, or an experienced physician. Exactly. To be I think those tools will be available at a much lower cost. So there will be a significant, I think in the past, the labs that could have cameras in the room and broadcast was very expensive to do all that. But that technology is proved to be extremely helpful during this time. So I think that you're going to see basically a tier level. So you're going to have, if you have a lower budget, you can buy a system that allows you to connect with, perhaps certain limitations, but you can go all the way to a very high level that you have a lot of technology to make you feel that you're in the room. But the ability to have anybody be able to be there to help you in a case, that's going to be, I think, move forward much faster than it was before.
Exciting times. I'm sure that we should be very, very excited with what is coming and not be afraid of the future and take the most of it. And I think we in interventional neuroradiology have already started taking the most of the future. And so this is NeuroTalks are a proof of that, and also all the webinars that you have been involved, and also the facility of the ability of sharing knowledge this way is definitely something that we should take that opportunity. And I'm taking this opportunity as well to thank you very much for your time. I know that you are between procedures, so I'm not taking more time from you. I welcome the opportunities to hear from you in the future again.
Thiago, thank you so much for this initiative. This was a true pleasure for me. I think it's a very good topic, and I really appreciate spending this time with you and everyone. Thank you so much. Take care. Stay healthy, okay?
Thank
Take
you.
care.
Let me, well, I don't know if he is gone, probably. No, you are still there. Well, I'm just inviting everyone. Next week, it will be slightly different. It's something that I've called NeuroTalks tutorial, because I'm going to talk about this time about anatomy of the external carotid artery and dangerous anastomosis. So it's a very technical talk next week, but I think it's important, especially for residents, and I think they will appreciate. So, and I appreciate as well your time. Thank you so much.
Bye-bye. Thank you so much. Take care. Ciao.
Thank you. Bye-bye.
Ciao.